All right. Again, we're going to have some of these maybe awkward, silent moments in the beginning of sessions just to let everyone join the session before we officially get started. All right. Well, welcome to the first official session of today's conference. Before we get started, one quick notice that we hope to have time to go through questions with Dr. York at the end of her session. So if you have questions throughout today's presentation, you can submit them through the Q&A feature on your screen. So any questions that you have, Dr. York and I will get to those at the end of today's session. And now I'd like to introduce you to Dr. York, who is a board certified neuropsychologist and professor of neurology and psychiatry and section head of neuropsychology in the Department of Neurology at Baylor College of Medicine. She is also the neuropsychologist for the Parkinson's Disease Research, Education, and Clinical Center at the Michael E. DeVakey VA Medical Center, also known as the PADRAC. Dr. York earned a master's degree and doctorate in clinical psychology from Vanderbilt University in Nashville, and she completed an internship and postdoctoral fellowship in neuropsychology at Baylor College of Medicine. Dr. York's clinical specialties include neuropsychological evaluation of adults with movement disorders and the differential diagnoses of dementia. She has been awarded 4 Faculty Excellence Awards for teaching and is the Director of Neuropsychology Training at Baylor College of Medicine and is a frequent presenter and educational partner with HAPS, as well as a member of our Medical Advisory Board. Today, Dr. York is going to be discussing the differences between normal aging, mild cognitive impairment, and dementia in Parkinson's disease, and hopefully offer some tips and takeaway for coping with cognitive changes for individuals with Parkinson's and their caregivers. So welcome, Dr. York.
Thank you very much. I am very thrilled to be here and to be able to talk to you about this today. So as Kathleen said, and thank you very much for the introduction, Kathleen, I'm going to be talking about explaining cognition in Parkinson's disease. And first, I'm going to just start by defining some terms to make sure we're all talking about the same thing when I say some of these words. And then I will get into the differences between normal aging, mild cognitive impairment, or Parkinson's disease, mild cognitive impairment, and Parkinson's disease dementia. And we'll define what each one of those things are also. And then I want to spend quite a bit of time talking about practical strategies for dealing with these cognitive changes. And this is not just for Parkinson's. So some of these practical strategies are for all of us, whether we have Parkinson's disease or not. So caregivers can also hopefully get some information out of this to help us. So we know Parkinson's disease is a movement disorder. It is diagnosed by the motor symptoms, and those are the symptoms that we can see. So it's a clinical diagnosis that neurologist makes based on the motor symptoms. However, there are a host of other non-motor symptoms that lie below the surface that we can't see, but that are happening in the body and in the brain of Parkinson's patients. And cognition is one of those non-motor symptoms and is actually one of the most common of the non-motor symptoms. So let's get to those definitions to make sure we're talking about the same thing when I say cognition. What does that mean? Well, those are all kinds of mental activities having to do with perception or how you see your environment, your memory, judgment, reasoning. It is pretty much every thinking skill that goes on in your brain. That's what we talk about when we say cognition. And in Parkinson's disease, cognition or cognitive changes are sometimes unexpected for patients and caregivers because they're told it's a movement disorder, and without a lot of information about the disease, they don't understand that there can be other changes that go along with the disease process. And actually, these non-motor symptoms and cognition in particular can cause more strain in a relationship than the motor symptoms. So we actually have some pretty good treatments for the motor symptoms that can stave off those those troubling motor, the tremor and the bradykinesia for quite some time. We'll find out later in this talk, but there's no magic pill for the cognitive changes. But it's important for us to recognize these signs and symptoms and understand what those changes are so that we can try to implement some strategies to try to help those. Another definition, and I'll be talking about, is dementia. And what is dementia? So dementia is a group of symptoms that affect memory, thinking, and social abilities. And it is severely enough that it actually does affect a person's ability to kind of function in their daily life. So whether it's they're forgetting to take their medications, or they can't pay their bills, or they're having trouble communicating. So this is a progressive cognitive problem. So dementia is an umbrella term. And when I say that, that means that there are many reasons why people have these progressive memory or other cognitive changes. And Alzheimer's disease is one of the most common dementias. But Parkinson's disease is also another type of dementia. And I'll talk about the differences between those two in a little bit, but just to understand that dementia is really an umbrella term. It is not a specific diagnosis. And so what we try to do is actually to figure out through neuropsychology and neurology what type of dementia a person might be having so that we can tailor a treatment for them. So I'm going to talk about the cognitive continuum. And what that actually means is that it's not, I'm going to start here first because we're going to start with some normal aging. So this says senior moments. Now, what did I come in here for? He's got carrots all around him. So if it comes back to him, it's probably okay. But that cognitive changes it's not a static thing. And it also is not something that changes very quickly if it is normal aging. And everyone, starting at the age of 35, unfortunately for all of us, it starts to be a slight downhill slope. And so there's slight changes that occur during aging. But sometimes there are more things that starts to change. And if someone is starting to notice that they're having some cognitive changes, that might fall into that preclinical stage. And we're learning more about that preclinical stage now through further research. What we do know more about now is the mild cognitive impairment stage. And this is where it starts to differ from normal aging. And this is where other people might start noticing some cognitive changes or some memory changes or inability to plan. And the person can still perform their activities of daily living, do the things that they can take care of themselves, but there might be more changes going on. And I'm going to talk more about this. And then from there, it could progress to dementia, which I talked about, which is those more severe cognitive changes that does interfere with their ability to perform their activities. So I'd just like everyone to realize that there is this cognitive continuum. And we're going to talk about that in terms of Parkinson's disease, but this is actually for all of us. It could be for all of us. So normal aging. And like I said, it does start to change no matter what, but these are very mild changes. And most cognitive abilities stay intact in normal aging. So you stay your bright self, your vocabulary doesn't really change over time. You're still able to problem solve and decision make. All of those things stay the same. Where people might have mild changes in cognition just due to normal aging is in things like short-term memory. But this is not something that, again, interferes, but this could be you have a quick senior moment, and the senior moments don't happen very often. Or you maybe can't come up with the words you're trying to say, but it comes back to you in just a little bit, or you're able to talk around it. So it's not interfering with your ability to communicate with others. Maybe it takes you a little bit longer to figure out a new problem, but you're still able to do it. It might just, you might have to sit down and focus on it a little bit more. So when we talk about Parkinson's disease cognition, what are we talking about with this, and what are we not talking about? And I think we're going to start with what it is not. So it is not Alzheimer's disease. Parkinson's disease changes in the brain are not the same pathological process that we see with Alzheimer's patients. So with Parkinson's disease, there are Lewy bodies in the brain, and that's the pathology that is going on there. While with Alzheimer's disease, there are things called plaques and tangles. So it's a different process that's happening in the brain. And that actually leads to different actual changes in cognition. So I'm going to say that, but unfortunately, the bad news is that just having Parkinson's disease does not mean that you can't also get Alzheimer's disease. And both of these pathologies can coexist in the brain. It is very rare that they do so. Again, very rare that they do so, but it definitely can occur. And Parkinson's disease doesn't turn into Alzheimer's disease. So again, different pathological processes that are going on. So the cognitive changes that are associated with Parkinson's disease, that doesn't mean that you're going to be getting Alzheimer's disease. So just to make sure that these are two different processes. Alzheimer's patients have very severe memory problems, and those occur very early on in the disease process, and that's actually how it's diagnosed. And they usually have problems in orientation. So that's who they are, where they are, kind of the date and time, those types of things. They also may have a whole lot more language problems like naming and visual perceptual problems, which is kind of making sense of what their eyes are seeing. In Parkinson's disease, and I'm going to again talk about this a lot more, they may have some memory changes, but it's not as severe as the Alzheimer's patient. And they usually have some problems in executive functioning pretty early on in the disease process. And I'm going to talk about that a lot more. So let's just take a step back and talk about Parkinson's disease cognition. And so over 50% of Parkinson's patients have cognitive changes throughout the course of the disease. So if you look at this pie chart here, you're going to see the yellow and the orange. Those are, the orange is the PDMCI or the mild cognitive impairment, and the yellow is the Parkinson's disease dementia group. So as you can see with that pie, over half of the pie is gone when you look at those two groups together. And about 30% of the Parkinson's patients do develop Parkinson's disease dementia. So this is not an uncommon thing that happens in Parkinson's disease. Really, at least 1 in 2 patients with Parkinson's disease will have cognitive changes throughout the course of the disease. But also to recognize that there are some individuals with Parkinson's disease, that whole blue group, that doesn't have cognitive change. So again, it's not that everything goes in Parkinson's disease in terms of the cognitive functions. Individuals with Parkinson's disease remain their bright selves. They usually know who they are and where they are, especially early on in this disease, and even when they start having cognitive changes. Their vocabulary and grammar, how they talk to you is pretty much the same, in that they're understanding what you're saying. And talk about some memory changes, but it's not all kinds of memory problems that occur. When it does come to Parkinson's disease, so I talked about with memory in terms of Alzheimer's patients. So Alzheimer's patients have difficulty getting the information in and then storing the information. With Parkinson's disease, you get the information in, the information is stored. It is there for later retrieval, but you may have trouble pulling that information back out of your brain. And so that's a big difference. So with Parkinson's disease, if you give a Parkinson's patient a cue, or remember we talked about that, it usually does come back. Oh yeah, I remember that we went to the birthday party. With Alzheimer's disease, that information's not there. It's never been encoded or stored, so they wouldn't have any recollection of that. One of the biggest things that I hear from patients with Parkinson's disease is that they have slowed information processing speed. And what that means is I feel like I talk about it in terms of wheels of your brain. The wheels of your brain just may be moving a little bit slower. They're taking a little bit longer to process that information. And that is called bradyphrenia. So we hear a lot in Parkinson's disease about bradykinesia, or the slowness of movements. Bradyphrenia is the slowness of thoughts. So Parkinson's patients may also have word finding problems where they can't quite come up with that word, or it's on the tip of their tongue, or they know it starts with a certain letter. Now, we all have these changes. This is one of the things that we all have these changes sometimes. In Parkinson's disease, it might be a little bit worse than normal aging would be. Perception is, I want you to think about it as your eyes see and your brain makes sense of what you see. So perception is actually how your brain is making sense of your environment, and that might change in Parkinson's disease. We talked a little bit about the short-term memory already, and then the problem-solving, multitasking, and reasoning. These are all examples of executive functioning. And executive functioning are more difficult, more complicated, integrative tasks that may interfere with someone's ability kind of to do things on a daily basis, because we use executive functioning all the time. So this cartoon says, "Hi, you've reached Susan's desk. I am monotasking right now, so I'll call you back when it's the phone's turn again." Beep. So again, doing one thing at a time. So Parkinson's patients may have a hard time multitasking. They may have trouble planning. So, and this may come into effect when you're trying to plan a vacation. What needs to start first? You know, you're getting the airfare, to get the hotel, just planning all the activities of when you're going and when you're returning. So for planning a vacation, it's actually a very complicated task because there are many steps that need to be taken. And that can be a difficult task for someone with executive functioning changes. And also, if someone is easily distracted by external noises. So if my dog were to run in the room right now and start barking, it might be very difficult for someone with Parkinson's disease to maintain their focus on my presentation. So like I said before, we do have actual criterion for Parkinson's disease mild cognitive impairment. And this came out of the Movement Disorder Society's task force, where up until 2012, we didn't have a diagnosis for this. We didn't have a way of classifying this all in the same way. So everyone was kind of doing it differently. And what that means is you have to have a diagnosis of Parkinson's disease. So that's kind of the first thing. And then there has to be a gradual decline in the person's abilities, cognitive abilities. And this can be either from the patient, from an informant, or a clinician, or a provider, a doctor noticing those changes. And it can also be found either on neuropsych testing that they have an impairment, or a cognitive screening exam. And those are often done in doctors, like a neurologist or a primary care's office. And it can be in one of these areas that I was talking about: attention, executive functioning, language, memory, or the visual spatial functioning. And again, for the mild cognitive impairment stage, it does not interfere with their activities of daily living. So they're still able to do all of the things they were doing before. In 2008, the Movement Disorders Society Task Force also came up with criterion for Parkinson's disease dementia. And so this one is you have to have Parkinson's disease and you have to have dementia. But it's dementia that is a slow progression within the diagnosis of Parkinson's disease. And there has to be an impairment in more than one of these areas. So for mild cognitive impairment, it should just be one area, or very, very mild in another. For dementia, it really does have to be two different areas. This has to be a decline from their previous level, and it does actually have to interfere with their daily life. And this is how we, as neuropsychologists, actually diagnose MCI and dementia in Parkinson's disease. So this is just a cartoon to show what is kind of differences between Parkinson's disease dementia and those with Alzheimer's disease. We've already talked about the memory, that in Alzheimer's disease, the memory portion is going to be worse than it is in Parkinson's disease, while executive functions will be worse in Parkinson's disease than in Alzheimer's disease. In language for Parkinson's disease dementia, I think the biggest thing that you see would be the word finding issues and not being able to come up with words that they say, that they're trying to say. While in Alzheimer's disease, it's more naming or understanding what the words mean. And visual spatial can be impaired both in Parkinson's disease and in Alzheimer's disease. And attention is also another one that because a lot of attention measures are timed, so Parkinson's patients tend to be slower on those tasks. So at baseline or at diagnosis, 15 to 40%, and that's a kind of a large range, I know, but that's because many different studies have looked at this now. But 15 to 40% of patients meet criterion for mild cognitive impairment in Parkinson's disease. So we used to think that the cognitive changes in Parkinson's disease didn't happen until much, much later on in the disease process. And that's because we were noticing those Parkinson's disease dementia changes. But because we have this Parkinson's disease mild cognitive impairment stage now, we're finding that actually patients do show some cognitive changes pretty early on in the disease process. And those who have Parkinson's disease mild cognitive impairment who meet criterion for that at baseline actually have a 5-time increased risk of progressing to Parkinson's disease dementia. So it's a highly predictive factor for the risk for dementia in Parkinson's disease. Okay, so that's a lot of bad news. And I hate to start the morning with bad news. So let's change it around a little bit and say, okay, let's take a step back and say, well, what can we do? What do we need to do about this? So first of all, I think it's very important to recognize that there are cognitive changes that go along with this disease. And some people, if they don't know that, think that they're going crazy. And just understanding that this is part of the disease process and that it's not, for caregivers, it's not something that they're doing volitionally or doing on purpose. That it's the disease and they can still be trying, but they just may not be able to do things like they used to be able to do. And so I call this kind of this green bubble here, the grace bubble, because you got to give yourself some grace if you're having some difficulties in these cognitive changes, and then also to have caregivers give themselves some grace and also the patient with Parkinson's some grace that this is part of the disease process and it's something that we need to try to work on and to do something for. Parkinson's disease mild cognitive impairment is the ideal time to try to implement interventions or to reduce the risk of more severe cognitive decline, to stave off changes to dementia. So even if you are starting to notice changes, it's not too late. Like, this is the time. Let's go ahead and try to implement some strategies to see if we can help. There are many factors that can affect cognition that don't actually have to do with the disease or could have to do with the disease also. But stress is a big one. So we all need to try to reduce our stress. And I know that's a big, huge task to undertake, but as best as we can, we need to try to reduce our stress and learn some good coping strategies. There are some medications, anticholinergic medications and sedative medications that can actually cause some fogginess and interact with individuals with Parkinson's disease. So talking to your doctor, to your physician or neurologist about those medications and making sure that you're not on any of those is a good first kind of step to make sure that things that we can help, taking those away or trying something else might help relieve some of those cognitive changes. I'm going to talk a lot more about depressed mood, sleep disturbances later in the talk, but I want to talk a little bit about infections, because urinary tract infections and other infections in the body can really do a number on cognitive functions. And this is something that if you're noticing a very short time of cognitive change, that it's happening very acutely, very quickly. They're becoming confused. So it's very important then to get in touch with your doctor and to make sure that there's not some kind of urinary tract infection or other infection going on in the body that's causing it's really called a delirium, which is an acute change in cognition that is maybe not related to the disease process. If you are noticing these cognitive changes and you've kind of taken these things into account, it's also important to get neuropsychological testing. So getting a baseline neuropsych testing after a diagnosis of Parkinson's disease can be helpful, because then we can actually look at all of these factors, see if there's anything else going on, talk to your doctors about the medications, and if need be, implement some strategies. So there is only one FDA approved medication for cognition in Parkinson's disease, and that is rivastigmine or Exelon. There are several other medications that are sometimes used off-label for Parkinson's disease cognition, cognitive impairment. And these were medications that were developed for Alzheimer's patients for the memory changes in Alzheimer's disease, but that some folks have found to be helpful in terms of cognitive functions in Parkinson's disease. And there are some studies that have shown some slight benefits with some of these medications. And those are galantamine, donepezil or Aricept, and memantine or Namenda. And again, I talked about reducing the anticholinergic medications, which are used for sleep and for bladder urgency and sometimes for tremor. So these are pharmacological treatments that your doctors can talk to you about. There are several, actually numerous experimental treatments that are out there, and I'm saying these are not for prime time because these are not on the market, or a lot of the medications are not on the market. So these are in trials now, and at Baylor we are involved in some of these trials, or have been in the past. So these are either drugs that were used for other things and now they're trying out for Parkinson's disease, MCI, or Parkinson's disease dementia, or they're novel medications or novel substances that they're trying to see if that will help the cognitive effects of Parkinson's disease. And then there are a host of non-pharmacological approaches. And some of these have been studied and some of these are understudied now for the cognitive changes. But again, none of them have been FDA approved for the cognitive changes in Parkinson's disease. So deep brain stimulation is FDA approved for Parkinson's disease motor symptoms, but what I'm talking about in terms of the cognitive changes in Parkinson's disease. I'm going to focus just a second on cognitive rehabilitation in Parkinson's disease. This is a non-pharmacological intervention. There is limited literature on the efficacy of this, on whether it works, and it's difficult to study. So cognitive rehabilitation is implementing strategies, compensatory strategies, or learning strategies to help cognition. And this is, it's hard to study because what is the outcome? Are you getting better on the computer test? Does that mean that things are better? Or we really want to see that you're getting better in your daily life and that you're able to do things maybe you weren't able to do before. So this is when I talk about interventions. Early Parkinson's disease, mild cognitive impairment is really the optimal time to implement these strategies. If someone has Parkinson's disease dementia, it might be hard to learn these new strategies and be able to implement those. We want them implemented early so that it becomes overlearned. It's just part of their habit of life, and so that can actually help their daily functioning. The problem with this is not a magic pill. We don't have a magic pill. So there's no magic pill for Parkinson's disease cognition. And this takes work. And sometimes it takes work with the patient and with the caregiver. So it's putting in the time to learn those strategies to be able to implement them later on when you might need them. There's some cons to this, is that it's very hard to find individuals who perform cognitive rehabilitation in Houston and actually all over the country. Part of that is because insurances don't cover cognitive rehabilitation, so for Parkinson's disease. So that makes it difficult to find individuals who can perform this as a profession. So what can we do? And I'm going to switch now and talk about practical suggestions. And again, this is not just for patients with Parkinson's disease. All of these strategies are things that we can all implement in our daily lives, and we all should probably strive to do. So prevention and looking at our vascular risk factors. So vascular changes are changes in our heart and our blood flow, and how that blood flow affects our brain and the blood flow through the brain. So things like diabetes, high blood pressure, high cholesterol, smoking, obesity, and excessive alcohol use are all risk factors for vascular changes, and all things that are able to be treated and controlled with either our work or work from medications. And we know that exercise in Parkinson's disease is a huge literature right now. We know exercise increases blood flow. And again, it's not just in Parkinson's disease, but for all of us. It increases oxygen to our brain. It enhances neurogenesis. What does that mean? It actually creates new neurons and may be neuroprotective. It helps create and enhance the interconnections of the different synapses or parts of our brain. And one of the main things it does is it reduces those vascular risk factors. So all those things that I said that can cause changes in cognition, it reduces all of those things. It also helps our mood. It increases our energy level. It helps you sleep better. And in many studies now, it has been shown to actually help and improve the motor symptoms of Parkinson's disease. And I'm going to tell you, it also helps cognitive functions. And so, one of the best things that you can do is get out there and exercise. And HAPS has so many different programs that are all free that you can attend, from Tai Chi to exercise to boxing to the marathon. So everyone needs to join in the HAPS 2022 Chevron Houston Marathon. So switching gears a little bit, this says socialize. Let us be grateful to people who make us happy. They are the charming gardeners who make our souls blossom, by Proust, who was a French novelist or author. So social interaction is one of the most complicated things that we do during the day, and we often just take it for granted. But it lights up or it activates many different parts of our brain in terms of what we're seeing and perceiving and what we're hearing and comprehending and actually being able to respond to them with word finding. So there's many different, it just activates so many different areas of our brain. So we should definitely try to make time for friends and for family and for fun. And I know during COVID, this is a little bit more difficult, but if everyone gets vaccinated, maybe we can get back to some normal social interaction, and I can actually give this talk to you in person versus over Zoom. But as humans, we are pre-programmed to be social. This is one of the things that makes us different from other animals. We actually, even introverts like me who don't mind being by themselves a lot, we are actually pre-programmed to be social, and we actually need that. It is vital to our emotional health and vital to our brain health. So one of the most important things to do is to get out and be social. And laughter seems to help people think more broadly and associate more freely. So it kind of opens up creativity. So getting out and having some fun and laughing. And there's been studies that have looked at this, and people who are the most active, social lives, had the slowest rate of memory decline in a study that was done by Harvard. And that's not for Parkinson's disease, that was for all of us. One of the things we need to do is to try to be socially interactive. And of course, during COVID, we need to do that in a safe manner, but we still should attempt to do that, meaning maybe go outside. There are some limits to social interaction, even if it's not COVID. So once we can actually go back to being a little bit more normal with our social interactions, is choosing settings that will help a patient with Parkinson's disease. Because social interactions can be so complex, it's helpful to kind of set some limits on what those social interactions are. So instead of the bottom picture there, that is a very highly crowded restaurant with tables that are all next to each other with so many people around, choose a smaller setting, and this one's outside for COVID. Choose quieter places and maybe just a couple of couples, so just one or two, that it won't be so overwhelming and there's not so much multitasking having to go on or divided attention. And it's important to try to help bring someone with Parkinson's disease into the conversation. If you notice that maybe they're having some difficulties following a conversation, is giving them some context of, oh, do you remember when we went to Aunt Polly's birthday party and you met with whoever, and kind of preface the discussion so that they are aware of what's going on and have time to process that information. So that slowed processing, and that can really affect language abilities, because if you're in a group and everyone's talking, they may be processing and wanting to participate in the conversation, but they may be still based on the last conversation and not know that it's changed. So making eye contact with the person you're talking with, slowing down your rate of speech. So I talk very fast, so this is something that I have to kind of check myself all the time on. Avoiding interruptions, especially if they're processing and their speech is slowed or slurred, trying not to interrupt them or let them actually kind of talk through and not finish their sentences. I'm not saying that you have to do this all the time. So again, give yourself some grace, give them some grace. I am not a patient person. Patience is a virtue that I work on. I have not mastered at all. Ask anyone in my family, but I work on it. And so if you don't do this all the time, it's okay. This is something that we can work towards. But if each day we're kind of working towards these things and at least have them in our minds, it can be helpful. So I said I would talk about sleep more. This is from William Penn, who is an English author. True silence is the rest of the mind and is to the spirit what sleep is to the body, nourishment and refreshment. And sleep is so, so important. So if I was in front of you, I would ask you, who here gets 8 hours of uninterrupted sleep a night? And I would not be raising my hand. Lack of sleep is one of the main things that can affect cognition and something that we can do to help it. So sleep affects our ability to consolidate memories. It's when we rest, it's when our brain rests. It takes all the information we've gotten that day and integrates it and consolidates it into memory that we can then use later on. It's actually when our brain is most plastic and most meaning able to move and change and grow. So fragmented sleep, which is very common in Parkinson's disease, and there's whole talks that are done just on the sleep problems in Parkinson's disease, but then things like REM behavior disorder, sleep apnea, insomnia, all of those suppress or push down our hippocampal functioning, which is the memory center of our brains. So if you're having sleep difficulties in Parkinson's disease, it's very important to talk to your doctors about this. If you've been diagnosed with sleep apnea, it's very important to use your CPAP. Find a mask that works. Try a different one if that one doesn't work. Keep trying. And if it falls off and you wake up, try to put it back on. Again, this doesn't have to be 100%. Try for it to be 100%. But if it doesn't and falls off, put it back on. And lack of sleep also affects our mood. So this is a big one also. Reduce distractions. A cluttered desk is a sign of a cluttered mind. Well, I don't like that. I like what Albert Einstein said. If a cluttered desk is a sign of a cluttered mind, of what then is an empty desk a sign? And if anyone could see my desk at Baylor, they would know that that's why I like this quote so much. But it's important for us to reduce distractions in our lives. So following a routine. So if something is that's how it is every day, it makes it much easier for our brains just to follow that routine. Making lists, and those can be very concrete lists. For someone with Parkinson's disease dementia, it could be this type of list: brush hair, brush teeth. For others, it might be, here's our activities for the day, but have it written down in a place that we can, that the family can see, that the patient with Parkinson's can revisit. And if you're keeping a calendar, actually make it a calendar that you see and then you mark the days off with, because just having a calendar up there may still be overwhelming for someone who's not sure, what week we're on. So marking it off and being like, okay, so this box is the one that we are on now. And with Parkinson's disease, we know that there are on and off times with medications. So with that, it's important to know when your best times are. So if you wake up after taking your morning medication and you're feeling good, and that's like your good time of the day, then that's when you should try to perform some more of those complex tasks, or have those discussions, or have the doctor's appointments, so that you're able to communicate with them and participate. If that's you're still kind of fatigued and that's not a good time, and actually once your medication kicks in later in the day, that's your better time, then try to change your schedule so that those more complicated tasks happen during those good times. And none of us can maintain our focus for very long periods of time. Actually, by now, in this point of my presentation, you have probably lost your focus about 15 to 20 times. That's okay. That's normal. You come back to me after a little bit and be like, okay, what's she talking about now? That's okay. Every task that we do should really only be broken up into 10 to 15 minutes. And because that's what our focus is. And so you might leave for a little bit and then kind of come back in, and that's all right. So I hate to call this woman out, but I saw this on the internet, and this woman is walking down the street. She is on her phone, and she does not at all notice that this kind of attic or whatever it is, basement is open, and she falls right in. We need to reduce our distractions, and the phone is one of those biggest distractions. Anything with a motor component in Parkinson's disease becomes a multitask, because the motor functions are no longer the overlearned, just automatic tasks that we do. A patient with Parkinson's brain actually needs to focus on the motor component. So walking and talking, walking and using a phone, walking and turning a door handle, all of those things become a multitask for someone with Parkinson's disease. And I noticed before that I said to avoid interruptions. And it is important to, if someone is working on a task, don't ask a question, let them finish the task first, or don't have the telephone or the phone ringing during all of those things. So don't have the TV on when you're paying bills. If you know that if an interruption happens, it's going to be hard for you to get back to that task. So another way is to provide structure in terms of decision making. So what are you in the mood for dinner is a much more difficult question to answer than do you want rice or pasta for dinner? So that reduces the number of options and allows someone still to be able to make a decision, but a much easier decision. This happens with my teenagers all the time. When I say, what do you want for dinner? I don't know. You want rice or pasta? Rice. So anything that can reduce the amount of choices will be helpful. And if you're concerned about safety, if you don't want your husband getting up on the ladder to clean out the leaves, which happened with my father, put the ladder away. Make sure it's not accessible. Or if you're afraid that they may not be taking their medications right, put the medications away and then bring them out when they're needed. Just try to, again, reduce those distractions and provide some structure. So I'm saying a lot of things of don't do this and don't do that. And I don't think it's all of that. I think we really need to plug into our lives. And if something is important and you really need to focus, you need the person to focus on that. And again, I do this with my teenagers. I've got a teenager who's got ADHD, and I do this, and it's a little silly, but come here, look at me right here. And I touch my nose and I say, this is important. I need you to focus. And just by saying the words, this is important, it kind of perks our brain up and gets us to focus on it for a long enough period of time that we can really listen and try to remember that information. And this is another thing that I do. I talk out loud. I don't talk to people I see or hear, but I talk out loud to remind my brain of what I'm doing. So when I set my glasses down in a place that I probably shouldn't be setting them down, I will say, I am putting my glasses on a table. There might not be anyone else in the room, and that's okay as long as people aren't responding to you then. But it provides another circuit for the brain to remember that that's where you put your glasses, or just put them back where they're supposed to be. So here again is my Albert Einstein, and he says that intellectuals solve problems while geniuses prevent them. So it's really important for us to compensate. We all, again, have some cognitive changes as we get older, and we all need to use compensatory strategies. I have my phone with me at all times, because without my phone, or what I call my brain, I don't know what I need to do or where I need to go or what Zoom call I need to get on. So use these strategies. They're out there for us, and they can make our lives much easier. There's no reason for us to have to remember that we need to take our medications at 3 o'clock, right? We have an alarm, as long as we've got our phone with us, or other alarms that can remind us of that. So that's one way to kind of take off some of the pressure that is on our brains and let something else help us, those external cues. And there are many different kinds of compensatory strategies. And I think whatever works for you is what you should implement. So try different things and see what works, and then implement those and use those. And then they'll become a habit, which will make it a lot easier. So a brain workout, if you don't use it, you will lose it. And this is a list of different, what I call high-tech brain stimulation. So these are some different websites or apps that people use to, these are cognitive apps. I am not a huge proponent of these. I'm not saying everyone should run out and do these. Some of these do require you to pay for them. I'll just tell you that, but I think it's important to let you know that these are out there. If these are things that you enjoy doing, if you enjoy playing on the computer, these are tasks that could at least stimulate your brain. So surfing the internet is different than playing a cognitive game and trying to beat your score from before. So again, if these are things you enjoy doing, then here are some suggestions of different places that I have found that patients have enjoyed. Whether these then translate into improvements in daily life is another story, and that's where a lot more research needs to be done. And again, I mentioned that surfing the internet doesn't count, because we really want these activities to be stimulating. They have to be kind of novel, and they have to kind of light up new parts of your brain and challenge you. So just staring at a television or just surfing the internet, and I'm not saying it, again, different than those apps that I'm talking about that should be challenging. But there's so many other ways that I would rather you got mental stimulation from. And hopefully you can choose some of these and add your own. But these are also things that you'll notice a lot of them are things that you could do with others. So picking out some of these activities and then doing them with others and socializing, again, COVID safe ways, are great ways to stimulate your brain. And the list can go on and on and on. And HAPS also offers a lot of different different activities that you can do. Actually, attending this conference in itself is a terrific way to stimulate your brain. So I also want to talk about managing your mental health, and this is for all of us. But in Parkinson's disease in particular, psychiatric symptoms are the most frequently reported non-motor symptom, with 67% of patients reporting at least one psychiatric symptom. And those are things like depression, anxiety, and apathy, or hallucinations, delusions, visual illusions, or impulse control disorders. So these are all non-motor symptoms. But for caregivers, it may be those also, maybe depression and anxiety, but there's also caregiver burnout, where again, in Parkinson's disease, this is not a short disease, right? And there's things that are changing all the time. It's not a sprint, it's a marathon, as the HAPS program says. So you need to make sure that you're taking care of yourselves, both the patient and the caregiver, because these can affect cognition tremendously also. So I want to end on this, which is to focus on your abilities, not your disabilities. And this is something that happens in rehab a lot. We talk about focusing on abilities, not disabilities. And as I was kind of changing this and updating this presentation, I often end my presentations with Peggy Chung. And actually, I was going to take it out this time because I was like, it's been done. I've done that already. But I looked through this and I decided to keep it in because she truly inspires me. And I think really shows that focusing on what you can do can really improve your life versus focusing on what you've lost. So Peggy Chung is an artist who lives in Hawaii, or who lived in Hawaii, I should say, and she painted, gorgeous pictures of her surroundings. So she was diagnosed with ALS. She was right-handed, diagnosed with ALS, and lost her ability to use her right hand. So she started painting with her left hand. And again, this is different than the first picture that I showed you, but still absolutely gorgeous and better than I could ever do. She's still doing something she loved, even though she had lost the ability to use her dominant hand. When she lost the ability to use her left hand, she started painting with the paintbrush in her mouth and using her teeth. And again, different than what was before, but she was still able to do something she absolutely loved to do. And when she lost the ability to keep the paintbrush in her mouth and use her teeth, she was using an eye tracker communication device and started painting with her eyes. And if that doesn't show you and inspire you that you can focus on what you do have and try to find something that you love to do and do it maybe in a different way. Think outside the box, but still try to maintain something and activities that you truly enjoy. So I want to thank you very much for your attention, and I am happy to take on any questions that you all might have.
All right, thank you, Dr. York. I am going to stop sharing your screen.
Okay.
For a moment. Okay, there we go. We do have a couple of questions and we do have a few minutes to still address them. So, all right, let me start with this. Can you talk again about, does a diagnosis of mild cognitive impairment guarantee a later dementia diagnosis?
So it does not. It does not guarantee that there definitely will be a diagnosis of dementia. However, like I said, there's a 5-fold increase of those who have Parkinson's disease, mild cognitive impairment, will go on to develop dementia. if they live long enough. So this is, many, many years down the road it could be, but they could remain stable for a very long period of time, and maybe just stay there, just stay stable.
Okay. And how often should a cognitive test be administered?
So ideally, in my ideal world, everyone would come into this world with their own neurocognitive testing that they would come in and bring to me, but that never happens. So I would want to see them kind of at baseline towards diagnosis, ideally, and then yearly. Or if things are really remaining stable, then every other year. So kind of by every 2 years. This is sometimes just not feasible due to there's not enough neuropsychologists out there to test everyone, and we're booked up. But that would be ideal, to be able to track progression and make changes. However, really just getting, if you're noticing cognitive changes, that's the time to come in. So let's come in, let's talk about it, let's see what we can do. And then, we can talk about when you need to come back in. Or if things are changing very rapidly, or you're noticing a lot of changes, then it's time to come back in.
Okay, thank you. Can you talk a little bit about how dementia and anxiety might affect cognition? I'm sorry, I think this was supposed to be depression and anxiety, though it's type dementia, sorry.
Okay, that makes more sense.
Yes.
So depression and anxiety, actually people who don't have any neurological disorders, those individuals with depression and anxiety actually do have cognitive changes. And it's usually in the areas of short-term memory. So they have kind of trouble coming up with the, a recent event or a conversation, and also in processing speed. So those are, two of the areas I've already talked about in terms of Parkinson's disease also. So those can exacerbate cognitive changes that are already occurring in Parkinson's disease and make them worse. So a lot of times, if someone with Parkinson's disease is successfully treated for their depression or their anxiety, they actually can notice a cognitive change in their daily life and improves because that depression and anxiety is successfully treated.
Okay, great. Thank you. Would, let's see, related to sleep, you talked a little bit about sleep, and there have been a couple of questions. One related to, I get a total of 8 hours of sleep in one night. Is it okay for it to be fragmented, or what should be the higher priority, fragmented sleep or unfragmented sleep?
Both. You should try to get as much sleep as possible. So for some individuals, it's just impossible not to have fragmented sleep. So trying to treat those changes, so trying to treat the REM behavior disorder or the sleep apnea is important. You want periods of time that you get into deep REM sleep. So that is again, our most restorative sleep is that REM sleep. And if we don't get all the way into that REM sleep, that's when the REM behavior symptoms can occur, meaning that you can act out dreams or yell and fight and kick. So those are definitely signs that you're not getting the restorative sleep. So taking a nap during the day is fine as long as it's a restorative nap and that it's not so long that it's interfering with your ability then to fall asleep at night. So a lot of times if you fragment your sleep so much that you're never getting into REM sleep, then again, you're not getting the sleep that you need to be able to restore your brain.
Okay, thank you. And what about prognosis? There have been a couple of questions about prognosis in terms of once there's a Parkinson's and dementia. There's probably a lot that goes into that, so that might be a difficult question to answer, but do you have any thoughts on that?
So when you're talking about prognosis, are you talking about is how are things going to change over time? And unfortunately in Parkinson's disease, it is very variable. It changes for people. Some people with Parkinson's disease, live for 15, 20, 25 years, and others, they progress much more quickly. And the same thing can happen in cognition also. unfortunately, I can tell you that a diagnosis of Parkinson's disease dementia is actually related to increased mortality rate, so that it does progress to mortality faster. But that doesn't mean that's for every single individual person. That was over a group over many long periods of time, like 12 years. So it's very hard to say exactly what a prognosis is with someone with dementia because it is highly variable in Parkinson's.
Okay, and a couple questions related to who does the neuropsychological testing.
So I'm a neuropsychologist. So clinical psychologists who train in neuropsychology are the ones that should be performing neuropsychological evaluations. Almost all of the main medical centers here have neuropsychologists within the Department of Neurology. At Baylor, we have 4, almost 5 of them, one starting next month. But each of the different UT has fantastic neuropsychologists, and I've been around so long here in Houston that I've actually trained almost all of them. Reach out to your neurologist if you're concerned about this and see if they've got a neuropsychologist that they work with. And even if they're not involved in one of the major hospitals here, we receive referrals from outside neurologists all the time and are seeing those patients also.
All right, thank you so much. I think it's important to know that once again, Houston is very fortunate to have the resources that we have here for folks with Parkinson's. And you're right. I mean, it's best to be kind of proactive. It's always good to get that baseline. So sometimes you might have to approach this topic with your physician instead of waiting for it to be the other way around. So thank you, Dr. York. That completes this session. I'm sorry, we're trying to keep everyone on a pretty tight schedule today. And so we've run out of time to hit the last remaining questions, but I did my best to kind of condense what we had received. We go actually into a brief break at the moment, and we will rejoin at 10:25 Central Time. Take a minute to just kind of stretch and move about. Then we're going to join the session on palliative care and Parkinson's disease immediately following the break. A couple things to note that kind of come in over the morning is that if you're having challenges with audio, one of the things that you can do is you can hit your refresh button. It may take you out of the venue, so back to where you kind of walk into the big building again, and that should resolve any audio issues that you might have. The other thing is that there are prompts when you join saying, allow the platform to access your microphone or your video. You go ahead and hit accept all access. We've shut all of that off. The people on the back end have shut all of that off. So your camera and video won't turn on in the middle of anything. And so there's no real access, but if you're having other issues, you can always hit that prompt, turn that off. And if you do have to come back in the building, you can always just hit the X up in the corner of that welcome video, which we're working to take down because you don't need it at this point. But if that does come up, just hit the X on that and it'll disappear, and then you can enter the building and then into the auditorium. So we'll see you back here in just under 15 minutes for palliative care and Parkinson's with Dr. Addie Patterson. Thanks so much. And thank you again, Dr. York.
Thank you.
Bye, everyone.
Bye-bye.